Okay, welcome. I'm so glad you're here this morning for Neuro-Ophthalmology. My name is Andy Lee. I'm from Houston, Texas. Susan Mollan from Birmingham, but soon to be Kingston, Ontario, Canada, and Dan Milea from Paris, France. So we invite you to participate in the discussion and ask us questions. The debate is mainly for fun, but also for learning, so please ask us any questions. If you wish to claim your CME credit, you should scan the entry and exit QR code, which is outside the hall on the signage. So with that, I will introduce myself on the first debate, which is all acute optic neuritis patients require high-dose corticosteroids. It will be me against Dan. My job is to convince you that every single patient needs to have intravenous steroids with optic neuritis. I have no conflict of interest with this particular talk, but I do have these disclosures here. And the Romans would say, amicus Plato sed magis, amica veritas. And it means Plato is my friend, but truth is a better friend. And so Dan, you are my friend, but truth is a better friend.
You were my friend.
So to the question, should we give intravenous methylprednisolone to optic neuritis? Dude, of course, Dan, of course. And the reason is, everything that you learned about optic neuritis from the optic neuritis treatment trial, don't believe any of it now. We don't follow that thing anymore, except for run-of-the-mill, regular optic neuritis. Still, you can follow the optic neuritis treatment trial. And the reason is, you need to know that optic neuritis has changed. It used to be that we knew a lot about optic neuritis, which was good, but now there are two bad guys you got to worry about. They're both antibody-mediated bad guys. One guy's name is MOG, myelin oligodendrocytic glycoprotein, MOG, and the other guy's name is NMO, neuromyelitis optica spectrum disorder, and that is aquaporin 4 antibody. And so the little white lies that I hope you'll erase from your memory bank from the optic neuritis treatment trial, which is from 1992, number one, optic neuritis always gets better. That's not true anymore. Optic neuritis usually gets better, and the demyelinating idiopathic forms do get better, but the bad guys, MOG and NMO, they need steroids. And we told you before with the optic neuritis treatment trial that it's going to get better no matter what you do. No steroid, it doesn't matter. You just get better faster with IV steroids. And in the optic neuritis treatment trial, we only did MRI of the brain, no contrast, no orbit, no gadolinium, no fat suppression. You cannot do that anymore. You need MRI, head, orbit, gadolinium, fat suppression, so we can see the extent of the enhancement and whether the enhancement is in the sheath or in the fat. And in the optic neuritis treatment trial, a normal MRI scan was a good thing. Good news, you don't have MS, but it's also a bad thing because the ugly antibody, NMOSD, and MOG, the bad, might be lurking in there. And we told you in the optic neuritis treatment trial that no labs helped, syphilis serology, ANA, lumbar puncture, none of that helped, but it's not true. We need to know if they have these antibodies because they could be bad or ugly. And so my dad would say, if it quacks like a duck and looks like a duck and flies like a duck, then it's the optic neuritis treatment trial. So whatever Dan is going to get up here and tell you, he's only talking about duck, okay? So whatever he says about that duck, that part is true. But anything else, don't believe him. So what does a duck quack like, sound like, fly like? It looks like this: a 20-year-old white female with acute unilateral loss of vision, pain with eye movement, a relative afferent pupillary defect, normal fundus, the patient sees nothing, the doctor sees nothing, there's nothing to see, it's a retrobulbar optic neuritis, and it just gets better, with or without steroids, and IV steroids gets you better quicker. So I fully acknowledge that if it's a duck, you don't have to give the steroids. IV steroids makes them get better faster. And what a duck looks like on MRI is multifocal white matter lesions, periventricular, ovoid, the whole bit. This is just quack, 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 duck. But what if the MRI scan is normal? Or the MRI scan shows lesions that are not typical for MS? Now you have to worry about the bad and the ugly. The bad is MOG antibody, and the ugly is aquaporin 4 NMOSD. So if you look at the optic neuritis treatment trial data, of course, IV steroids makes you get better quicker, but it really didn't matter for field whether you got IV steroids, placebo, or oral steroids. Everybody got better. And the same thing for visual acuity. Everybody gets better. They get better faster with a steeper slope if you get intravenous steroids. All that's still true about the duck. But we do not want to poke the bear. Do not poke the bear. If you poke the bear, he will come and eat you. The bear's name is antibody-mediated NMOSD and MOG. And so if you look at poking the bear, it looks like this, oral steroid. Do not give oral steroid. That is poking the bear. Intravenous methylprednisolone placebo, if you look at the recurrent optic neuritis rate, your chance of getting a recurrence was higher if you poke the bear with oral steroid at conventional dosing. Do not poke the bear. And these are the bad and ugly bears that you need to be looking out for. The first is called MOG, myelin oligodendrocytic glycoprotein. The second is called aquaporin 4, which is NMOSD, neuromyelitis optica spectrum disorder. They both are B-cell mediated, antibody mediated, cross blood-brain barrier, and for MOG, the target is oligodendrocyte, myelin oligodendrocytic glycoprotein. And for aquaporin 4, the target is the aquaporin 4 water channel on the astrocyte, and that could get ugly real quick because it kills the astrocyte. So if you kill the astrocyte, game over. And they need to have an MR head, orbit, gadolinium, and fat suppression because what we're looking for is sheath enhancement, or the enhancement is going outside of the nerve parenchyma. If we see either of those, that is not quacking right. That is not a duck. That is not your father's optic neuritis anymore. And if you look at MS in the world, it's the same latitude in the northern hemisphere as it is in the southern hemisphere. The equatorial regions don't have as much MS. And so the reverse is also true. When should you worry that this is not a duck? If you walk in the room and it's a brown person, or it's a black person, or it's Afro-Caribbean, or African-American, or whatever your population is, if they're from these areas here, you should be thinking about non-MS related optic neuritis. And if you look at the world map showing NMOSD, which is that aquaporin 4, you can see it has a worldwide distribution, but the rates are much higher in this band here between the MS latitudes in the northern hemisphere, 30 to 40 degrees, and in the southern hemisphere, the same. So if you look at rates in the US for African Americans, that's 11 per 100,000. And for our Afro-Caribbean population, that's 10 per 100,000. And so if you look at visual recovery for patients, it is dependent on timing. And I just want to call your attention to these little Snellen charts here. Patients treated later than 4 days had an 8x chance of failing to get back to 20/20. And if you waited 7 days, 10x risk. So delay of the visual treatment with IV steroids, and for NMOSD and MOG, we're going to be thinking about IVIG and plasma exchange very quickly in those patients if they're not turning around. So MOG is myelooligodendrocytic glycoprotein. It's bad. It's a more aggressive antibody-mediated condition. It's not as bad as NMO, but NMO is really ugly. The clicker is not advancing. Can you just advance it? So one of the things that I want you to take home is this optic nerve enhancement. Don't let neuroradiology read it as just optic neuritis. They have to say how much of the nerve is enhancing, whether it's unilateral or bilateral, and longitudinal extensive enhancement is defined as more than half the nerve is enhancing. No, go on this clicker. Can you advance it? And I just want to mention to you that NMOSD is often misdiagnosed as multiple sclerosis. That's 50% of the cases are misdiagnosed. Next. And earlier diagnosis and treatment definitely makes a difference in NMOSD. And the one thing I want you to remember is, if you look at cumulative survival rate for the Kaplan-Meier, for NMO negative, that's that dotted line, versus NMO positive, which is that red line, within 10 months, you can see half the people are going to have another event. And if you wait long enough, half those people are going to get a transverse myelitis TM event. And that means paralysis, death, blindness. So, because you can't tell if the duct is optic neuritis MS at onset, you have to order these tests. And if you look at, again, NMO negative versus MNO positive, percentage patients are going to get transverse myelitis, you can see that 80% of the people are going to get transverse myelitis within 25 months. They're going to be paralyzed, so it's not just about their vision. So, in summary, you should know that we told you some little white lies about optic neuritis in the optic neuritis treatment trial. That it always gets better, that's not true. That it improves with treatment whether you give it or not, that's not true for these bad guys. IV steroids makes you get better, that's still true for a duct. You only need an MRI of the brain, that's not true. You need brain, orbit, gadolinium fat suppression. A normal MRI used to be a good thing, but now it's not. And so you should know that it can be good, quack, 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 quack. It could be bad, and it can be super ugly. And please don't poke the bear. IV steroids for every optic neuritis. Thank you for your time and attention. And now my esteemed colleague, Dr. Milea, will do the impossible, which is try and argue against me in my own session.
Can I have the slides, please? Right. So the debate is all acute optic neuritis patients need high-dose steroids. So this is where I work in France, in Paris. The Rothschild Foundation Institution is a wonderful building and a wonderful institution with lots of patients dedicated to eyes and brain. My disclosures, I have a couple of grants, no relevance to this, but I'm also the editor-in-chief of a journal, Neuro-OPHTHALMOLOGY, and you are most welcome to submit your best papers to our journal. So, yeah, this is the title of the debate. I pretty much have to agree with Andy with this title, except for one word, which is, so Andy, yes, you are absolutely right. Everything you said is correct, except one word, which is all. No, not all. So I'm looking at you. Do you say yes to everything all the time in your lives?
Yes.
So have you seen that movie, the Yes Man, Jim Carrey? Yeah, so you remember?
Yes.
Yes. So he used to say yes to everything until trouble started in his life. So, and things went south until he learned to say no as well. So ONTT, Andy told you, everything he told you is absolutely right. So we changed a lot our minds. And in fact, I'm going to play for your team, Andy, saying that there is one thing in the ONTT that people don't stress enough, which is that steroids, as Andy told you, the final visual outcomes were the same with or without steroids. But there's one thing that steroids were very helpful for, is to protect against MS at 2 years. And that was a major finding, and I don't know what you guys think, Susie and Andy, but that hasn't been really continued. In Paris, in France, my mentor, at that time he said, well, this is so clear. If at 2 years the patients have less MS after steroids, IV steroids, well, after 2 years, probably the effect is wearing off. That's why people join, in the end, the same risk of MS. So he was treating everybody every 2 years with steroids. He never published the data, but I think it's a very interesting concept. I'm playing for you, Andy, here. And Andy says there's the bad, the ugly, but there is somebody else in the game, the bad, the ugly, and the horrible. He forgot to tell you about the horrible. And I'm going to tell you about the horribles. So absolutely, Andy is right. So we don't know at the beginning. When patients show up, if this is MOG or aquaporin 4, it takes a couple of days or weeks, depending where you are, to have that definition. And to the point that optic neuritis treatment trial has been challenged. And this is Axel Petzold and Gordon Plant, who said, there should be a new treatment trial. We should ask better questions than that landmark study, the ONTT. And these are the horrible ones. I agree with you. There is the ugly, but they're the horrible. And what's the horrible? Infection. Steroids on infection, it's not good. And there are a number of cases, and I'll show you a couple of examples, where patients with optic neuritis have been mistaken as having infection. Let me show you a case. A patient, age 27, no family history, with bilateral, painless, rapidly progressive visual loss. Maybe optic disc swelling, not very clear. Those are the visual fields. And his vision initially was counting fingers bilaterally. He was treated with steroids, as Andy would probably say. And after steroids, oh, he went even worse. So what is this? And Andy, Andy's favorite expression is, nobody goes blind in my department without a cure of steroids. This is exactly what happened to this patient, and he went down. Why? Well, look at his OCT. Because he had the central serous retinopathy, chorioretinopathy. It's an exceptional case. After 3 days to have central serous due to steroids, but it has been described. And guess what? Did this help him? Not really, because the diagnosis was not even optic neuritis. The patient did not improve. He got worse. The final diagnosis was Leber's hereditary optic neuropathy. And we know that 30% of patients with Leber's hereditary optic neuropathy get steroids for nothing or just for an encounter with a horrible. I'm not going to talk about syphilis because those are things that you should rule out before giving steroids, but toxo could be another thing that we're not looking for. Of course, this is not a typical presentation of optic neuritis, but this is a visual field that could put you on the track, the Jensen's visual field defect. And of course, steroids are certainly not good if you are dealing with a toxoplasmosis. So in conclusion, always use steroids in optic neuritis. Are you always saying yes like Andy says? No. Dr. Lee is right. There is a current shift towards steroids, and I'm joining him 100% for that. But never say always. And remember, steroids can be harmful, infection, central serous, etc. And I found, Andy, a picture of us many years ago. You should be worried. Same meeting, COPHy, I don't remember, Istanbul. Dr. Arnold smiling, Dr. Neil Miller, you recognize him. And you see a guy who clearly says yes. That's Andy. A guy who's more worried, and that's me. Thank you very much.
We have time for some discussion now. If you could come up to the mic. While you're thinking about your question, I'll let Susie arbitrate and say what she's doing in real-world practice, and then maybe we could summarize, because these debates are meant to be provocative and confrontational and funny, but really, at the end of the day, you need to know what your take-home message is, and I don't want you to leave with, we don't know. Okay.
So we've had a complete shift in the United Kingdom. We took the view that we wouldn't treat optic neuritis with steroids because of the results of the optic neuritis treatment trial, but that's completely changed in the last sort of 3 years, where all our patients will, and it's because of that band that Andy showed in the United Kingdom. We predominantly have Caucasian people coming to us. We do have a sizable portion of patients that are from Afro-Caribbean descent, and those patients, absolutely, you need to think about MOG and NMO. So it is interesting that they want to repeat the optic neuritis treatment trial. The problem is getting the patients early enough at the sign before they actually lose their vision, because I think that's where the money is. Dan?
Yeah, I fully agree. However, I practiced in Singapore for 12 years, and I can tell you, MS is such a rare disease. And as Andy said, I know a guy who knows a guy who heard about someone who had MS in Singapore, right? On the opposite, I would test everybody for aquaporin 4, and the numbers were absolutely stunning. And this is very different from what I see now in Paris, where we probably see 150 to 200 patients with optic neuritis a year, and probably less than 10 with aquaporin 4.
Okay.
and we're testing them, So I'm not saying it doesn't exist. I'm saying that the proportions are a bit different, as you said, Andy.
Yeah, so that's that latitude thing again. So amazingly, and Dan, you'll appreciate this, the latitudes in the northern hemisphere and the southern hemisphere where the wine grape grows is the same latitude for multiple sclerosis. So if you walk in the room and you ask your patient, do you have good wine in the place you're from? If they say no, you should test that person for NMO and aquaporin 4 and MOG, because all those middle places where the wine grape doesn't grow, like Congo, there's no good wine in the Congo. So that person needs to have testing. And the other thing I think you're hearing from the group is the demographics matter. In Asia and in Singapore, that you should be thinking about NMO, which we used to call de Vick syndrome, the Asian form of MS. We don't call it that anymore. And then if you're in the UK, where you have this huge immigrant and expat populations from other countries, you really should be thinking about testing those people. And the US is our population is Afro-Caribbean, African-American, that's our NMOSD population. But MOG, it doesn't care. For that one, it's just less likely to be MS when it's a brown person or a person from another country.
Now, an interesting question is what happens if an Asian person immigrates to the United States very early during his life? Does it have the risk for MS, the place of origin or of the arrival? And that's a very interesting question. And in fact, it depends what age he's emigrating. So I don't think any Asian in the United States should be suspected for aquaporin 4 first. I don't know. But it depends really, asking him, or her, when did you move to the United States? So after the age of 12, usually it joins the risk of the original country.
I think the other thing that in Andy's talk was really a take-home message for ophthalmologists is really getting that MRI early, because that's really going to help. And I know in some centres that's really difficult to do. And you really have to ask for the correct sequence. They have to be fat saturated and with contrast, so you really get the idea of longitudinal extension. And that really helps us. So in Birmingham, we would get an MRI as quickly as possible, because those patients with NMO and MOG that you put on high-dose steroids, you're going to want to move them across to plasma exchange really early, because often their vision doesn't shift in those early days.
So in the US, if they're not turning around by day 3, we are switching to plasma exchange. What are you guys doing in France and UK?
We're a little bit longer. We're trying to get that MRI, and that's where we put pressure on our radiology colleagues, because we're sort of saying, you're going to help us determine whether they stay on high-dose steroids or they move across to plasma exchange, because obviously the antibodies take about 6 weeks to come back.
So counting fingers, visual acuity, from day 1, we probably go for Plex in France, right? And steroids, by all means, of course, yeah.
And so that's the other point of what Dan was telling you. That means some of the patients are going to get Plex and they have labor. But I think that's just going to be such a hard differentiation to make. Bilateral, simultaneous vision loss, question to count fingers. So that's where I think the MR is helpful. But some Leber's patients, their nerve enhances and their chiasm enhances. So you can't even use that to differentiate it. So Dan, we're just going to have to accept we're going to have some Leber's get plexed?
Yeah, I think that's the price to pay. So one of the hopes is we're doing now a lot of work using artificial intelligence. There is a good rationale to think that the pathology in the retina could be different, even in retrovalvular optic neuropathies, if it's MOG versus common optic neuritis, and we're trying to pick a signal looking with artificial intelligence of OCT data. And that would be wonderful to say, okay, we have an argument to say this is probably more like common MS sort.
So if you have a question, please come up to the microphone. I will just emphasize another point that Dan made about the OCT. So it's going to be very tempting not to do an OCT on someone whose nerve looks normal, but that's the person that actually needs the OCT. Because the nerve is normal, you have to run that OCT through the macula, not only to see the subretinal fluid that could be the real diagnosis, but there are other things, macular edema, macular holes. I mean, when you're in the ER, you don't You can't see some of these things, and OCT just sees way better than you. It's just a way better test. So OCT is not available in the emergency room. So it's really incumbent upon ophthalmologists, before you send the patient to the hospital as retrobulbar optic neuritis, that we do the OCT beforehand. Even my hospital, which is like a really good hospital, has no OCT in the emergency room. So if they get into the emergency room, there's no more OCT. I don't know, what are you guys doing?
And they would definitely come to us, so we would do an OCT, and it goes back to the point of picking up other optic neuropathies. So you do your nice disc, but you're also going to do a nice sort of ganglion cell analysis. And then you do pick up some nutritional, but you can also pick up Leber's hereditary optic neuropathy. But I've been stuck in that situation with that OCT, but still wanting to have to plex somebody,
Right.
because you just don't have those tests back.
We're quite liberal about plexing people. I don't know if we're wrong or right.
Yeah, I mean, I think that's another paradigm shift that you're hearing is, not only are we moving towards treating everybody, if they're not getting better, we're going to this plasma exchange. And for ophthalmologists, that means you need to find a friend, because there's no way you're doing this by yourself. This is not a do-it-yourself project. This is a team effort. There is no I in team. You're the eye doctor, not the team doctor. We need to find a friend and phone that friend, and that friend is usually neurology. What do you guys do?
Yeah, no, we definitely have a good team working with neurology, and actually we've moved to sort of day case for these patients, so they sit in a chair on an ambulatory care ward, so they're not taking up bed space, and hopefully very soon we're moving to peripheral plex. That's our kind of next step, to make sure it is a sort of day case thing, that these patients come in every day for 5 days.
There's one thing I would like to comment, which is one thing that's very dear to Andy, which is, why are you doctors? Because you care about patients. And the most important thing in this era of, new technologies, AI, all these things, your clinical skills are absolutely critical. And some little signs can put you on the track back for aquaporin 4, for instance. I remember a patient we saw with optic neuritis, and he, the resident was telling, oh, no, nothing relevant. He just got exploratory abdominal surgery for unexplained hiccups 6 months ago. That's neuromyelitis optica, right? Area prostima enhancement, and that was the thing. You knew exactly on the spot that this must be aquaporin 4, which was confirmed subsequently. So your clinical skills and, talking to the patients is absolutely critical.
So the take-home message for all these debates is, the question was, all acute optic neuritis require high-dose corticosteroids? Clearly the answer is not all, and if it's typical MS optic neuritis, follow the optic neuritis treatment trial and use your best judgment, but everybody else, we're shifting to IV steroids. So we're going to move to the next debate now, and it's temporal artery ultrasound, whether that should replace the temporal artery biopsy in giant cell arteritis. And Dr. Susie Mollan is going to be taking the pro position.
Thank you. I'm not quite sure why Andy put this in his session to chair, because we're in Europe, we're all European, and as I'll show you, this is our preferred way to investigate giant cell arteritis. So I do have some disclosures, but they don't relate to either biopsies or ultrasound. So just to remind ourselves about giant cell arteritis and why it's a really popular topic for ophthalmologists, is because it's really hard to investigate these patients. They come in with sight loss, it's very difficult, they have systemic symptoms, and we have to work through our diagnostic pathway. And it often takes a little bit of time to get to the diagnosis of giant cell arteritis, but you need to treat immediately if you suspect there's giant cell, because otherwise patients lose vision. And I had a patient that I got phoned about this week who's sitting on a ward in a hospital close to where I usually work, who's gone bilaterally blind, because what happens is these patients come in through internal medicine and they don't often get picked up as quickly as they should. So the eye signs we're all good with, the anterior ischemic optic neuropathy. Don't forget cranial nerve palsy. These patients can come in with what looks like possibly a presumed microvascular palsy, and then 6 weeks later, if you don't pick up it's giant cell arteritis, they will go blind. There are some rarer signs in the retina, including arterial occlusions, and very, very occasionally you get a posterior ischemic optic neuropathy where you actually see nothing. So you always have to have a high index of suspicion for giant cell arteritis. It takes a full history, and we've really got to think about those constitutional symptoms and the other systemic symptoms that these patients have. And don't forget to ask about polymyalgia rheumatica. 1 in 5 patients with polymyalgia rheumatica will go on to get giant cell arteritis. They get treated with low levels of steroids and can still go blind. So it's really important to ask about polymyalgia. And there's a spectrum of the disease. So we see the cranial spectrum, and our rheumatology colleagues generally look after the large vessel GCA and polymyalgia. But with the advent of new imaging, we know that large vessel vasculitis actually is part of the cranial GCA that we all see. And I'll show you a slide a little bit later that reminds us of that. So this topic about ultrasound versus biopsy is not controversial in Europe. And so our EULAR guidelines from 2015, 28, and yesterday I was in London with the guidelines that we were setting up. And guess what? We're still promoting ultrasound as the first line investigation in giant cell arteritis. So what we're going to do is we're going to in the patients that we suspect, we're going to take the bloods and we're going to find a friendly rheumatologist to help us. And one of the reasons to use ultrasound is it's generally done by rheumatologists, and they're invested in the disease. They're going to be looking after these patients long term. Who here really wants to look after a patient on high-dose steroids who's living with increasing years? You're going to give them diabetes, you're going to make their hypertension worse, you're going to make their bones frail. As ophthalmologists, we really don't want to be dealing with this kind of patient, so it's important that we actually allow our rheumatologists to be able to help us not only in the diagnosis but the long-term treatment. So yes, it might not be the only thing we have an argument with the States about this week, but the American College of Rheumatology recommends biopsy, and as you know, our EULAR group recommend temporal artery ultrasound. Now, there is a problem with the title of the talk, because when we think about temporal artery ultrasound, we think about just scanning the temporal arteries, and our rheumatology colleagues don't do that. They do the carotids, they do the subclavians, they do the axillary. It takes about 45 minutes to do that, but it gives them a lot of information. And they're not just looking for a single halo, they're looking for halo counts. So we'll go to temporal artery biopsy. There's a lot in the literature. It really, people can tell if I've reviewed their paper when they talk about gold standards of a temporal artery biopsy. And I'm going to show you a slide in a minute that shows you temporal artery biopsy is not the gold standard. It is invasive. There's a variable sensitivity, which you'll see in a minute. And actually, it's not a well-taught procedure, particularly in the hands of an ophthalmologist. If you have vascular surgery, it's a little bit different. But certainly where I practice, you cannot get the vascular surgeons to do this biopsy for you. And it's prone to delayed access. So the patient comes in, they're on high-dose steroids, and somebody schedules the biopsy weeks down the line because they can't get an emergency slot. It's difficult to do temporal artery biopsy. And there are complications of it. Because it's not well taught, people often injure the facial nerve and people end up with a brytosis. It's not unusual for me to see a brytosis sent in from another hospital. And the patients really, really hate that, particularly if it turns out that the biopsy is negative and they actually don't have giant cell arteritis, they may have a different condition. The sensitivity of the biopsy, if you look at the bars and they just don't overlap, and it's because we're not good at doing biopsies, particularly in the hands of ophthalmologists. Often people send tissue that's not artery, and that can happen because, you know, the area is very ischemic, it's difficult to, pick up the artery itself, but often it's done because people are not well versed in this procedure. So the sensitivity is poor and wide, and specificity is high, but there's still a big part of those confidence intervals that need to be tighter for this kind of procedure. So it's a trade-off between the sensitivity and specificity, but it also depends on your pre-test probability. So temporal artery ultrasound is a first choice, as we know. It is actually not invasive at all. We like to talk to our patients during the time that the rheumatologists are scanning the patients. They're actually talking to them about their history and how they're getting on, and they get an immediate feedback of what's going on with the patient. It does take high technical skills, so there are courses that people go on. There's the usual one in Austria, in Innsbruck, every year, which is really popular amongst the Europeans, and there's an increasing number of Americans are coming over to learn the technique. And so it's good for diagnosis, but it's also good for disease severity. So they have a halo score now rather than just the halo sign or the compression sign. And it already identifies a subset of patients that are going to do badly. And that's really important because we're now in the era of second-line therapies and biologics for GCA. The New England Journal of Medicine has just published a further study looking at a JAK inhibitor. So not only do we have IL-6 inhibitors, we also have JAK inhibitors. So it's really important that we understand which patients are going to do worse with their GCA. So I was going to say, Andy, what do you think this is? Do you know what it is?
Picasso.
Picasso. So this is fool's gold. So this goes back to this reference standard. Everybody writes temporal artery biopsy as a gold standard. And this is the best bit that came out of the Temporal study. And what it shows is if you have ultrasound or you have biopsy, it actually doesn't generally matter which you're doing because of the inter-observer variability. And what that means is you can do a beautiful biopsy, but you're so dependent on your histopathologist actually making the right call. And it's actually the same with looking at videos of ultrasound. So we feel that ultrasound is definitely not the reference standard, but it certainly is much better than temporal artery biopsy in terms of its availability and its invasiveness. So just that slide again. So temporal artery ultrasound is dynamic. It's dependent on the expert that's going to look after that patient. It's repeatable, so you can do it, and people do it at each visit. The patient comes and it scans multiple territories. The artery biopsy is binary. It is really dependent on your surgeon and very much dependent on your histopathologist. And if you do temporal artery biopsy and you don't know who reports your temporal artery biopsies, on Monday morning you need to go find them and talk to them and say, well, what do you include as giant cell arteritis and what do you not? And you might be very surprised. So when we look at sort of looking through the literature, it really shows that temporal artery biopsy, there's a low test accuracy when they put the statistics to it. And just in my last 20 seconds, I just wanted to show you this. This is a really good paper to have a look at. So it's a diagnostic classification for vasculitis, DCVAS, and it combined with a North American cohort. And it's thinking about GCA. We think about GCA and the eye, and we forget about the systemic disease. And really what this showed was that if you just do biopsy, you're going to miss a quarter of patients. So GCA have more diffuse disease, and they also often have bilateral subclavian and axillary involvement. So it's really important that you actually think about multimodal imaging for these patients. So do you want to rely on something that gives you complications and is binary, or do you want to do something that's dynamic and is going to take that patient to the expert that's actually going to treat them? So I would recommend temporal artery ultrasound. Thank you.
So I'm going to tell you the truth now. Can you load the slides? The truth is, pre-test probability of disease is the most powerful predictor of post-test probability disease, not the tests. So we can argue about tests, but the thing that makes the difference is pre-test probability disease, and that's not a test. Doctors make diagnoses, not those tests. So should temporal artery ultrasound replace the biopsy for GCA? And you heard America versus Europe, it's still an ongoing debate. I do have these disclosures, and my main disclosure is I'm from America. So, should we do this? My name is no. No, 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 no. The reason is I'm not saying no forever. I'm just saying no for now. What it means is it cannot replace pretest probability of disease. So if your pretest probability of disease is low, and you saw what Susie showed you, 20% pretest probability, it doesn't matter what test you do, they all suck when you have pretest probability of 20%. But if you have pretest probability of 90%, then all the tests are worthless also, because it doesn't matter what that test shows, you're going to still treat that person. So the sensitivity and the specificity of the test are not the deciding factor for whether you should do the test or not. It's what your pre-test probability of disease is, and then you have a post-test probability based on a likelihood ratio. So a temporal artery ultrasound is not the same as a biopsy. You heard that. Giant cell arteritis is too high stakes a decision to rely on the ultrasound alone. It's probably too high a decision to rely upon a biopsy alone. And the sensitivity and specificity are not sufficiently good enough yet to replace temporal artery biopsy because of the other thing you heard, which is it's very operator dependent. So the whole problem with biopsies and ultrasounds is it's very operator dependent. So if you trust your ultrasonographer and you trust their data, then by all means, go with it. But you don't know. And the same thing is kind of true for biopsies. The halo sign and the halo score can be used, and I'm not saying you shouldn't use it. I use it. I use it when the patient refuses or can't have a temporal artery biopsy, or it's going to take too long to get it. I use it for relapses because I don't want to biopsy them again, but you can do the ultrasound over and over again. And if their response of GCA to therapy is in question, I'm going to do it because I can see that it's either doing something or it's not doing something. And if my initial biopsy is negative, I might go the other way, where we do the biopsy first and then we do ultrasound second, or I might do the ultrasound first. It just depends on the clinical circumstance. But the bottom line is, if your pretest likelihood of disease is low, then any negative test is good enough. Because the pretest is low, any negative test, whether it's biopsy or ultrasound, if that's negative, you don't need to do anything else. The post-test probability is low. And the reverse is also true. If the pretest probability of disease is very, very high, like 90%, then it doesn't matter what test you do. If it's positive, you're going to treat. But if it's negative, you're probably going to treat. And so these are the grades of evidence, and Susie alluded to this a little bit. Grade 1, randomized controlled clinical trial. We really don't have a head-to-head in the United States that we would feel comfortable that it's grade 1. Grade 2 is what you heard about, non-randomized or other studies, and non-experimental designs. Grade 4 is because Susie said so. And so that translates into the real world. If it's a grade 1, level 1 randomized controlled clinical trial, that's a must-do. That's standard of care. This question is not a must-do. Should do. Should do means you should do it or show just cause why you didn't do it. Could do is where we are right now, practice option. Voodoo, it means so new it might not be true. And then there's do-do, don't do it. So we are talking about could do, not must do, not should do. It's probably not voodoo, but it might be a little bit of doo-doo. So if you look at the exact same data set, these are 50 patients who compared ultrasound to biopsy proven. The sensitivity of the halo sign was only 40%. That sucks. And 81% specificity. And so if you convert that to likelihood ratios, then you take that number, pretest probability, you run the likelihood ratio through a Fagan nomogram, and you get the post-test probability. And so when you compared to clinical, the sensitivity was only 42% and the specificity was 94%. What that means is you're the doctor. Doctors make diagnoses, not these tests. The conclusion, biopsy remains necessary in most cases, irrespective of whether the halo sign is present. Now, the thing you got to look at is the date, 2013, because you saw that Susie had those dates down there because the ultrasound just keeps getting better and better and better, and people get used to doing it, and so the sensitivity and specificity number has changed over the last decade. If you look at this BMC paper, 575 patients, half of them had final diagnosis of GCA. The halo sign was only 68%. Specificity was better, 91%. So what does that mean? If they see the halo sign, if the pretest likelihood of disease is high, that's good enough. You don't have to do a biopsy. But that sensitivity number, that kind of sucks. And all of these studies have the same problem, heterogeneity of the studies. So the halo sign, it's relatively sensitive and specific, but it's not as good as what we would consider to be the fool's gold standard. And false positives are bad as well. So if you get the halo sign and it's not giant cell, well, Dan told you about every bad thing that could happen horrible with corticosteroids. So up to 4.6% of the patients who had the halo sign that didn't have giant cell. And it's not clear why that happens. It's probably the same problem Susie mentioned, which is operator dependent. And in this paper, 7 of 9 of these patients, steroids were not only felt to be unnecessary, but harmful. So you heard about what the halo sign looks like, and what it looks like on histopath is that halo is lymphocytes. So the lymphocytes cause this hypoechoic ring around the artery. And so what we're really arguing about is why is there this disparity between the United States, American College of Rheumatology, and the EULAR, European League, and we're arguing about the same numbers, which is what sensitivity and what specificity are you willing to accept on any given patient that would obviate the need for a temporal artery biopsy. And I think this is the exact same paper, which is there's positive and negative likelihood ratios. So we're using the exact same data set, and we're coming to dramatically different conclusions. So to me, if you have the halo sign and you have a high pretest likelihood of disease, they're 80 years old, they're no light perception, they have pallid edema, they have jaw claudication, this is good enough. I don't need to subject this person to an invasive biopsy. It's good enough. And again, I think this is the same data set. You can look at the wide variability. So we do not want to have confidence intervals that are this wide. We want that confidence interval to be very narrow, and we certainly want them to be grouped around a single number. And when we have this kind of disparity, regardless of whether it's a giant cell arteritis temporal artery biopsy or a temporal artery ultrasound, you know that our data sucks. So that is what we are showing you. Our data is not that great for the 2 tests that we are relying upon. But if you look at the specificity, you see it's better. The halo sign, way better. The numbers are clustering closer together. We really don't have this widespread. It's heading towards the right side. And if you look at the years that these papers are being published, it keeps moving to the right. So the confidence interval and the specificity of the halo sign is getting better and better and better as the operators become better and better and better. So how do I use the temporal artery ultrasound in my own practice? If the patient refuses or cannot have a biopsy or can't have it in time, as Susie said. So hospitalized patients, forget it, I'm not getting no biopsy for 3 days. And my ophthalmologists don't want to do the biopsy. So it's not just the problem of they can't do it properly, they don't even want to do it. And if you have a high pretest likelihood of disease or a low pretest likelihood of disease, I think the ultrasound is very helpful for those cases. But if you have an iffy pretest likelihood disease, if you have a negative ultrasound, I'm still going to go to the gold standard temporal artery biopsy, even if it's fool's gold. And I use it for possible GCA relapses. I use it to judge efficacy of therapy. And if the initial biopsy is negative, you're going to have a hard time convincing the person to do the other side, especially if they got that brow ptosis thing. So that person also gets the ultrasound. So in summary, a temporal artery ultrasound is not a temporal artery biopsy. They both suffer from the same problems of sensitivity and specificity. Giant cell arteritis, however, is probably too high stakes a decision to rely upon ultrasound alone. If the pretest likelihood of disease is high and you get a negative ultrasound, I'm still going to go to temporal artery biopsy on that patient. And the sensitivity and specificity of the test are so wide that you can't replace the temporal artery biopsy yet, but it's getting there. And every year it keeps moving, the confidence interval keeps moving to the right. And I already told you the times I use it. I think it is helpful, and I'll just share with you what we are doing. But before I do that, my name is no. My number is no. My sign is no. You cannot use this ultrasound alone. Doctors make diagnoses, not those tests. And I thank you for your time and attention. So we'll turn it over to Dan. Dan, what do you say?
I don't know.
Good answer.
Right. No, I don't think there is really a conflict in what you're saying, really, guys. I think, honestly, I think I would probably use what's available. That's first thing. But I was very interested, Andy, how do you, or Susie, you alluded to this, how do you follow on ultrasound the efficacy of treatment? Is good data on that?
The monitoring isn't brilliant data, actually.
Right.
We're not quite there yet. And a lot of the rheumatologists now will combine ultrasound with doing like a CT PET. So, you know, they're using lots of different imaging modalities. They say in their hands with their patients, they feel it helps, particularly if they think somebody's flaring. There's a lot of talk about, you know, subclinical changes within the arterial walls and what does that actually mean. So I think we will hear more about that sort of monitoring piece. I mean, my feeling is that as ophthalmologists predominantly here, we're all really, really busy, and these are not the sort of patients you want in your clinic. So if you have a rheumatologist, you know, who's interested in sort of vasculitis and giant cell arteritis and they want to do ultrasound, I would quite happily send my patients to them, that they get the full sort of holistic look after, because steroids, as you said, are so bad, and they're so bad in this population. I think the other thing that neither of us said in the talk, but it is important to say, that if you are going to use second-line therapies in terms of an IL-6 or a JAK inhibitor, you need a confirmatory test. Most reimbursement in the countries around Europe require you to have a test. So though you might have a barn door, this is definitely giant cell arteritis with a chalky nerve and stuff like that, you need to have proven that it is GCA.
Yeah, so what we did at our institution to answer this sensitivity specificity question is we did a full year where we did both tests on every single patient. Yeah. And then we had our own internal audit of the data so that I could feel comfortable with my ultrasonographer. So in the beginning, the first half of the year, he was terrible.
I think,
but then later he got better.
Yeah, that's the other thing to say. It depends on who you choose. So in my hospital, I actually go with a consultant radiologist who's not that invested in the patient, but in other hospitals around near where I work, they've got rheumatologists. I think if it's a rheumatologist who's doing the imaging, I have a lot of confidence in that because they're going to look after the patient. I don't have a lot of confidence in people that just use, you know, ultrasonographers that are in the department, you know, scanning an ankle and then, you know, doing something else. So I think, as you say, Andy, it's having confidence in that person, but you need people, because the issue is if that person goes on holiday and you need, you know, the ultrasound, they need to be in a team. And rheumatologists have fast-track services now. You will have heard of these. They're quite common in certain countries, so in Germany and in certain areas in France, and actually, interestingly, also in Scotland.
Now, it's interesting. We published a paper recently in JAMA Ophthalmology. We're assessing people with GCA, AION. And we were very worried what are going to be the standards evaluation across the world. If it was a large population, it's going to be biopsy or ultrasound. And guess what? The editor said both are fine. As long as they are positive, they are fine.
Yeah, I think that is where we're heading. If you have high enough pretest likelihood, any positive test will do. And then what Dan said, use what you got. So I have found that the ultrasound, I can just get it so much faster. And so sometimes I have to use the ultrasound because I have no choice. The other thing that we have done is we do the carotid. It's called a temporal artery ultrasound, but really they're doing the carotid. So that is an easier sell to my department, that you're doing a carotid and the temporal artery ultrasound is just added on there. Otherwise, they didn't want to do a study just to prove that they were getting better at doing the halo sign. They said, what are we getting out of this? I'm going to order a carotid Doppler that I wouldn't have ordered otherwise. So it really was helpful, but the weird and amazing thing about it was we saw the same thing that you saw happen with the data over years, happened within 2 years of my ultrasonographer having biopsy confirmation, because every case I could say, look, here is what we saw. And then they started to learn what to look for. Otherwise, if you're just looking for that halo sign, it's not that great.
Andy, can we ask people in this room, how many of you have access to a good ultrasonographer? Raise your hand. Okay, end of the talk.
Well, see, that's the thing. That's the problem I have with the EULAR. They get in a room, and it's all these people who their whole life is a giant cell, and then you get out in the real world, and you try and explain to the people, and they say,
I'm really sorry.
they say this. And so that's where we need you guys to come to the microphone, because a lot of times we learn more by coming to other countries than we are teaching, because we don't know what it's like to be outside the ivory tower. We don't know what it's like to be on the front line of these disorders. And so it's very interesting to see that, because that is your European recommendation. Ultrasound is your European recommendation.
Well, let me get further. How liberal are you about doing temporal artery biopsies? Liberal? Yeah.
Yeah, that's the traditional teaching, right? You have to do 10 biopsies to get like 3 positives. Yes.
Okay, I just want to ask you if Susan think that in the future, for the problem of the imaging of the technique, we ophthalmologists could approach to learn this kind of imaging.
They're really, really keen to get ophthalmologists on board, but I just have no time in my clinic. 45 minutes with one patient is a car crash in my clinic. So yeah, I'm fully on board with people, wanting to do it. In fact, actually, if you look up the EULAR, they have this session in Austria every June. So definitely.
It's joined by the ophthalmologists also that want to learn that.
Yeah, there's various sort of different specialties like internal medicine go and things like that. So, but they'd be very welcoming.
Okay.
And the one thing I was going to say was what was interesting is this sort of story. We've talked a lot in the past about using aspirin in giant cell arteritis, and I was going to ask Andy, do you prescribe aspirin if somebody comes in not on aspirin, when they're new onset?
I give them a baby aspirin, but the data sucks. So
Yeah.
don't do it, because it's not evidence-based. It's a could do.
It's a could do.
It's not a should do or a must do.
Yeah. There is some new data coming out of Sweden to show that patients that get diagnosed with giant cell arteritis within the first 6 weeks are at quite high risk of either having a stroke, which was related to atherosclerotic disease and not giant cell, and also myocardial infarction. So I think when some of that big sort of data studies hit, and I know it's sort of cohort studies, it's going to open up that whole Pandora's box again about, do you give aspirin, do you not give aspirin? It really is down to thinking about the patient, because there are risks in this age group of giving aspirin.
Yeah, so we use a risk calculator for what was just given, so that we have the could do, should do thing. So you plug in their age, their blood pressure, their cholesterol, all these non-giant cell arteritis related risk factors, and then it gives a predictive number at the bottom, and then you have to put that number in against the risk of the aspirin, which is 1 in 3,000. So again, doctors make diagnoses, not these machines. AI is going to come and take some of our jobs, but maybe it won't be your job. So AI is not going to take your job, but the doctor using AI is going to take your job.
Sure.
Dan, do you give any aspirin?
Yeah.
I do it. I do it especially for the TIA kind of people, transient diplopia, the transient vision loss people. I don't know if it does anything. Are you doing it?
Yeah, I am, and I think it goes back to this idea about, you were saying getting carotid Dopplers. I think what we'll see is a shift in the next number of years where it'll be a bit like central retinal artery occlusion, where somebody actually has to go and have their vertebrals and their carotids scanned. And it will be particularly important with the JAK inhibitor as well, is the other thing.
Yeah, the other point I'll make is for the TIA people, we are doing the carotid Doppler anyway. So just adding that onto the carotid protocol to do the temporal artery ultrasound is not that big an ask. So even though you guys answered you don't have an ultrasonographer, that's not true. You do. You just don't know their name. So you got to go home and find out when you write carotid Doppler, who is doing that, and you go take them out for coffee and say, hey, do you think you could just add on this temporal artery thing for us? Because it could be GCA. And you'll be the hero if they find the halo sign on that stroke workup. Okay, well, I will, I'm going to present some cases now. All right, are you guys ready? So the name of this is Duck, Duck, Goose. So you already heard what I mean by quacks like a duck, flies like a duck, but sometimes it's a goose. So don't get your goose cooked. Same disclosures. All right, so I already told you what a duck looks like, and we're not going to talk about this except I will let our panelists say what they do for ducks. 20-year-old, white female, acute unilateral loss of vision, central vision loss, RAPD, other eyes normal, pain with eye movement, short segment of enhancement. You see that short intraorbital segment, not longitudinally extensive, not in the fat. All right, duck, 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 duck. Susie, what do you do for this?
So we're going to give a short course of steroids. We're going to see them back within 2 weeks and make sure the vision's got better. And then I'll see them in about 3 months after that. So you have to make sure that they plot over time, that they're doing the duck thing, that the vision goes down in their boots and then comes back to near normal.
Dan?
Same.
Are you both ordering the aquaporin 4 and the MOG on this, even if it's a duck?
Depends where. In Singapore, yes. In Paris, no.
It depends on when I've got the MRI. If I know that I can walk around and get an MRI that day and I see that, then I'm not sending the bloods. But if I have to wait a couple of days, I've already sent the bloods.
So in USA, we are ordering the blood even on quack, quack, duck, because I've been burned by the duck. The way I get burned on the duck, though, is when the MR doesn't show MS. Right. Then I have to go back and order it. And because the steroids can make the test go negative, that's where I get burned. If you give the steroids before you draw the labs, it might make the blood test go negative. And Susie told you that for giant cell biologics, you need something positive. For the FDA-approved drugs in the United States, you have to have seropositive, otherwise they don't pay for the drug. So it's super important that if you're gonna order the test, order it before the immunosuppression, let alone plex. If you plex it, for sure the test is gonna go negative. What are you guys doing in this setting?
Oh yeah, I mean, if you're thinking about going to plex, definitely the blood's already gone.
Okay, so Dan, I change one thing. Instead of making the fundus normal, I make it that fundus there with the peripapillary hemorrhages, or I make it the cotton wool spots. What would you do differently if it's peripapillary hemorrhage, optic neuritis, papillitis, or these cotton wool spots, if anything? Would you do something different on these cases? If the disc, everything's the same, 20-year-old, white female, acute loss of vision, RAPD, but instead of having normal fundus, doctor sees nothing, patient sees nothing, you see something. Does it matter to you if you have papillitis, hemorrhage, exudate, cotton wool spot?
Certainly, in every case. Yeah.
So what would you be doing differently on these people in Paris?
Well, starting from the right, neuroretinitis. We all know the cause of neuroretinitis, Bartonella, all that sort of things. Cotton wool spots, I would be interested about vasculitis. I would be interested, if it was an older patient, I would seriously question giant cell arteritis. Depends, but you said it's a young patient.
Yeah, it's the same
it's the
duct,
same, right.
but I only changed the fundus. So your job is the top row, and then we'll let Susie do the bottom
Okay.
row. But the top row, what should we be ordering? Because in the optic neuritis treatment trial, they said you don't need to order any labs in the optic neuritis treatment trial, but that's only for quack, 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 quack duck. If it doesn't quack right, including the fundus is weird, you do have to do labs on this. And Dan told you about syphilis. It can always be syphilis. I don't have any experience with that, but Dan, you probably can comment more on syphilis.
It's on the rising scale, absolutely, syphilis, as you know.
Because it's France.
Oh, probably. Certainly. Yeah.
So syphilis serology, all three of those? get the
Systematically, no matter what, even the duck, well, she will have
same-
syphilis.
Even the duck gets
Oh,
the syphilis
100%,
serology.
100%. That to me is a big message.
Tuberculosis screening,
Not in France, not in Singapore.
UK?
No, not. I'm looking at those. No.
India,
not,
yes.
Not off the bat.
So in US, because we have all these endemic people, and because I voted for give everyone IV steroids, I'm getting a quantiferon on all the patients. How about Lyme disease? You have Lyme disease in Paris and UK?
Not in
No.
Paris. In Copenhagen,
Copenhagen,
plenty,
yeah, yeah.
plenty.
Copenhagen, yes.
Yes.
How about
Sweden.
Seville? How about Spain? You have Lyme disease. Borrelia, Burgdorferi, or no, never.
But India, TB would come up
Yeah.
very high on the list, I guess, right?
Anything else you would order? So would you do the MOG and the NMO if you have the star figure?
No.
No.
No. How about the cotton wool spot?
It looks a bit unusual, actually.
No.
Yeah,
No.
yeah.
How about the hemorrhages?
Oh, yeah.
Yeah.
Yes,
For sure.
so you should
Definitely.
know that one too. So the peripapillary hemorrhages, the edema one, you definitely order the MOG and the NMO on those patients, MOG especially. Cotton wool spots, that's more likely to be vasculitis or hypertension or antiphospholipid or something else. And the star figure in the US, that's quantiferon, Lyme, syphilis serology, but Bartonella henselae, cat scratch fever, number one. You got cats in Paris?
Plenty.
Okay, so how about lumbar puncture? Would you do lumbar puncture with just papillitis? Would you do lumbar puncture with cotton wool spot? Would you do lumbar puncture with the macular star figure? Dan, no?
Papillitis maybe, unilateral, not even sure.
How about bilateral? Everybody.
Yeah.
Everybody.
So that's really important what they just said. If it's bilateral disc edema or bilateral star figure or bilateral, you'd spinal tap that. So that's not you, that's find a friend, phone a friend. Because you're about to give the IV steroids. And what if it's meningitis or something terrible like fulminant IIH?
Well, I was about to say, make sure that you ask for a measurement of the opening pressure. I know our neurology colleagues are meant to do that at every tap. If you're saying, oh, it's bilateral optic neuritis, they may not measure the pressure. And one of the differentials is actually fulminant IIH. So be careful of that one.
And talking about that, oligoclonal bands, very unusual in aquaporin 4, as you know, right?
So we're definitely going to be doing lumbar puncture on bilateral people with disc edema. How about if it's retrobulbar? Are you going to do spinal tap on that?
In a unilateral?
Unilateral? No.
No.
Even for MS, oligoclonal bands, none of that stuff.
No, our neurologists have really moved away from that.
All right, how about bilateral?
I think bilateral is different, yeah.
Okay, Dan, would you do labor tests on anything in the top row?
No.
So can you tell them a little bit about the type of disc edema or pseudoedema that we see in labor? When would you order the labor test? Of course, if it's bilateral, male, central scotoma, but when do you do it?
So you all remember there is no true optic disc swelling in labors. It's pseudo optic disc swelling. So if it's typical optic neuritis, and with optic disc swelling, it's obvious I wouldn't think about labors. I would think about labors typically if it's sequential, a male, the typical story, or if I just don't understand the thing. It happened, you see patients with MS, for instance, with optic neuritis who do not recover at all. 5% in ONTT of patients with optic neuritis do not recover well. You remember that.
So now let's say a patient with MS and optic neuritis doesn't recover. That's called Leber's. It's called Harding syndrome. It's the association between Leber's and MS. It is not that infrequent.
Yeah, that was a really important point. So my dad would say a good lecture, he was writing down things he was going to do differently when he got back home. But a great lecture was the names of patients that he had to call back. So if you have patients that you said, wow, this person had MS, but they didn't get better. What did Dr. Milea say? He said order labor testing on the MS patient who didn't get their vision back. So if you're thinking back on your practice right now, there's probably one or two of those, because in the optic neuritis treatment trial, we told you that 5% of those people just don't get better. Sorry, you're just out of luck. But some of those patients actually have labor. Okay, Susie, you're on.
None of those are optic neuritis. No, I don't think I can go home. None of those are optic
Not
neuritis.
quacking right? Is that what you said? What are those?
They're horrible.
What is that white thing?
I don't know. It's disgusting. No. So for these patients, I actually think OCT is really good and wide field imaging. So the sort of vasculitis type picture that you're seeing over here, fog in the headlights, that would be definitely going towards my uveitis colleague. But you can see there's also changes on the vessels there. But I would get a sort of high density through the optic nerve, because I have been caught out with subretinal abscesses and things like that, particularly in patients that are immunocompetent on critical care, that kind of thing. Have you stuck in a SANS one?
Yeah, this person's not an astronaut.
No, he's not an astronaut. I was just
The
checking.
choroidal folds, what would you do differently with the choroidal folds disc edema person?
Well, I wouldn't do much differently if it was bilateral in terms of if they had disc edema, I would go down that pathway, because there are a small percentage of patients with raised intracranial pressure that have folds. But I just wondered there, was it, is it a thyroid patient or something like that?
Yeah, so that's the traditional teaching. Something's behind the globe pushing and making those folds. The disc edema is just a consequence of whatever's behind your eyeball. So that definitely needs the orbital imaging, that person. Okay, I changed the age from 20 to 50. Doesn't matter, Dan. The top row, does it change anything? 50.
50.
Same workup.
It's early. No, it's early for second. I would really concern about giant cell arteritis. A bit early, 50.
How about 80?
80. No matter what ultrasound says, it's giant cell arteritis.
Could that first one be giant cell?
First one?
The hemorrhage with the pebble?
No, not really.
How about the second one, cotton wool spots? Can that be giant cell?
That's what it is.
How about the macular star figure one?
No way.
No way. But you would still work it up if they're 80 for
For
giant cell?
GCA, the last one? No.
No.
Susie?
No, I wouldn't. But also, I mean, the pattern of the cotton wool spots in that middle one is more like a malignant hypertension, so you'd
True.
be looking at both sides. The GCA cotton wool spot tends to be right next to the disc or on the disc, rather than more spread out from the disc.
There's one thing, Andy, that I highly disagree with this exercise, is that we don't see the periphery. It
Yes,
is so critically important. We've seen patients with optic disc swelling due to very peripheral toxoplasmosis that was overlooked because people don't look at the periphery.
No, I think Susie mentioned that too. Definitely we're going to get retina involved and when it looks like
Right.
any of these, because we're neuro-ops, we're not scleral depressing the periphery, so we need them to look out there. And the one I've been burned on is ARN. It's like acute retinal necrosis, but it's way out in the periphery, and the disc just happens to be swollen, and it gets sent to me by accident. But it's herpes out in the periphery. I changed the healthy status to immunocompromised. Would you admit all immunocompromised people?
Yeah.
Renal transplant, admit.
They've usually been admitted.
They're already admitted.
They're already
Yeah, right.
admitted.
Yeah.
So.
How about pregnant lady? Admit.
Maybe not the Bartonella.
Not the
No.
Bartonella, everybody else? White thing, scary thing, disgusting
Yeah.
thing,
Yeah.
everybody else gets admitted. So for me, if they're immunocompromised, they're a survivor of a transplant of any kind, or if they've had a malignancy, they're getting admitted. And if they're pregnant, I admit all these. because I don't want to fool around with pregnant lady. I don't.
If you suspect giant cell arteritis, would you admit all your patients?
We try to, particularly if they're infirm, because of the risk of steroid psychosis, and I've had quite a few in my time, and a couple of patients who have swinging vision. So those patients that are really having that amaurosis fugax, those are the sort of patients that we might actually think about IV tocilizumab off the bat if we're really confident with our diagnosis. There's loads of reasons not to admit patients these days because of cost and beds and stuff like that. But giant cell arteritis kills people, and in little old, I shouldn't say little old women, who are sort of really slight and maybe only 45 kilograms, if you're going to whack them with high doses of steroids, you're going to cause diabetes and other problems. So having them on board, teaching them about steroids, getting the diabetic team to have a chat with them, I think is really helpful.
Do you admit your patients?
We are admitting when they're getting intravenous methylprednisolone. If they don't have any vision loss, we work with rheumatology outpatient. But if they have vision loss, or they have the amaurosis fugax version or the transient diplopia version, they're getting admitted, IV steroids, and monitoring the steroid side effects. So I hope what you've learned from this part of the exercise is that bilateral, simultaneous, rapidly sequential, that's not quacking like a duck. Severe pain, that's also a weird thing. Most patients with optic neuritis just say pain with eye movement, but you have to kind of coax it out of them. The severity of the disc edema, a macular star figure, cotton wool patch, or any other disgusting white stuff, you need to probably get uveitis on board. Choroidal folds, something behind that eye. And if it's not acting right, NLP, or as Dan said, it didn't get better. You treated it and it just didn't get better, or if it recurs. So all of those are not quacking right. So you need to be aware when it's not a duck. The other thing is the nerve enhancement. So Susie, would you do anything different if it's intracranial enhancement or if it's chiasmal enhancement?
No, but I mean, I've had MS chiasmitis in the past, but I wouldn't do anything different. These patients would be admitted. They'd get their sort of 3 days of IV in the time that it gets them set up for Plex. If I saw that and we could get Plex earlier and get the line in, they would get Plex earlier. But it just takes a bit of time. We do it through our renal physicians. So,
Dan, are you admitting chiasmitis?
Oh yeah, 100%. Aquaporin 4, that's the biggest concern, as you imagine. And number 2, the second diagnosis I would be quite concerned about, it's sarcoid.
So that's a really important point that you just heard. If you just move the enhancement from the nerve just a little bit back into the chiasm, we're going to get freaked out by that. So we are admitting all those chiasmitis, tractitis, anything other than just the short segment of orbital enhancement, I'm admitting all those. All right, Susie, it's a 20-year-old white female with acute unilateral loss of vision in the right eye, to count fingers. They have an RAPD and a normal fundus, but the other eye has that.
oh, they're definitely getting a really nice scan, and it'd be pituitary views to get that sort of skull base chiasm view to see what's going on.
Why?
Because I'm worried they've got a tumor pressing on their chiasm.
So how fast can you get a scan if it's Friday, 4:45 in the NHS?
It depends whether I've bought them beautiful biscuits back from Seville.
So if it was Friday, 4:45 p.m., but it was
I'd
just regular optic neuritis, would you pull in the biscuit favor?
No, I wouldn't pull in the biscuit favor.
How about if it's got this superior temporal field
Yeah,
defect?
I would pull in
Can
the
you
biscuit
tell
favor.
them why that little thing up there makes that much difference to you? This?
Yeah.
This matters to you? It's like
It does matter. Just because of depending on where the compression is on the chiasm.
So that's a really important point, that you have to test the other eye. The patient's going to say, why are you even doing that? This is my bad eye. This eye is 2,200 or count fingers.
I think the importance is of actually getting a field as well, because our sensitivity to confrontational visual fields is really bad. So I actually even struggle on a Friday afternoon to get a visual field. We're lucky in Birmingham that we've got a lot of fellows, so usually what they do on a Friday afternoon is do the fields and OCTs so that we can actually see the patients.
Yeah, it's super important that you do the field on the other eye. So if I let my residents see this patient, they're gonna say, count fingers vision, I did the confrontation, it was fine, in the other eye. I'm like, we need a field on the other eye. And that's because this lesion is at the junction of the optic nerve and chiasm, and it can mimic optic neuritis because it's usually like an ophthalmic artery aneurysm or pituitary apoplexy, or it's something that's bigger all of a sudden, so it looks to you like retrobulbar optic neuritis, but retrobulbar optic neuritis doesn't go to cause that junction thing, which is from the nasal crossing fiber. We used to call that the von Willebrand knee. Dan, do you believe this thing exists or not?
Depends if Jonathan Horton is in the room.
There's a very good paper in Eye. Andy's one of the neuro-ophthalmology editors at the Eye Journal, which is Springer, and on some of my slides later on, I've got a QR code to it, and there's a beautiful, quite a long paper, I think it was 10,000 words, talking about the anatomy of the chiasm and how we should rewrite it. Just going back to your last one, the one thing we did say, because we're saying that Friday afternoon thing, don't accept a CT scan. That's the major thing is if you go around on Friday afternoon and they say, hey, you could just push it through the A&E scanner, the chunky cuts that you get, you're just going to miss the pathology. So really demand the MRI. Say it's absolutely, I'm going to send them for an MRI anyway. It's no point giving them the radiation of the CT.
So we use a 5 test object when the vision is worse than 2100, and we are testing the other eye for that little superior temporal field defect in the fellow eye. Patient sees nothing, doctor sees nothing. This is retrobulbar optic neuritis, but as soon as it goes to that little thing in the sky there, it actually doesn't matter whether Willebrand's knee exists anatomically or not. Its localizing value is the same. And that's because you're at the junction of the optic nerve and chiasm. So you probably learned this diagram. You're trying to decide between this one, acute unilateral loss of vision, RAPD, normal fundus, optic neuritis, quack, 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 but then duck, duck, goose. That superior temporal thing. Move this lesion to right there. And it actually doesn't matter whether this little Willebrand's knee thing, which goes into the contralateral optic nerve for a short segment, if you just push this back, who cares? Lesion is still here. So the lesion is here regardless of whether this thing exists anatomically or not. You don't have to believe this exists to know that the localizing value is to the junction. And the junctional scotoma, as Susie said, is almost always something bad. Even if it's enhancing, like chiasmitis again. That's a junctional chiasmitis. So it's bad no matter what it is. So the differential diagnosis from this thing right here, the junctional scotoma, is badness, badness, and super badness. There's nothing good that causes the junctional scotoma. They're all bad. And of course, in this person, it was this. It was pituitary apoplexy. And it can totally mimic an acute optic neuritis. And in the optic neuritis treatment trial, there were 2 patients that were enrolled by accident that did not have optic neuritis. One was this, and the other was ophthalmic artery aneurysm. So we're looking for, on a duck, is just a little bit of enhancement in the intraorbital segment, and longitudinally extensive for me is more than a half of the nerve. So it's more than half the nerve. That's the marker that it's not quacking right. And what Susie told you before is you have to suppress the fat. So you see the fat is very bright on T1. If you don't suppress it, you won't see that, because white stuff on white stuff is white stuff. So if you don't do the fat suppression, you will not be able to see that little segment of enhancement, and that's super important to see. So the fat, we got to make it go away. So we need fat suppression, MR, head, orbit, gadolinium. All right, Dan, is this optic neuritis? It seems like this tram track thing. What do you think about that?
I would be concerned about MOG, obviously, because there's orbital involvement.
Yeah, so that's another thing I hope that you're taking away. The MOG, if it's in the sheath and it's perineuritis, we used to call this optic perineuritis. And some of the patients had this chronic relapsing thing, and we called that chronic relapsing inflammatory optic neuropathy, CRION. But we cry about that now because it's MOG. It's MOG. A lot of things that I thought were idiopathic in the past are MOG. Like ADEM, acute disseminated encephalomyelitis. I used to say, how sorry, you have optic neuritis. You got it again. I don't know what's wrong with you. But a lot of those were MOG. Susie, are you ordering the MOG on ADEM and perineuritis?
Oh, definitely on, well, if I saw perineuritis, definitely. With ADEM, they tend to go to the neurology team, so I don't, or pediatrics.
So for me, that's the same thing. The way I get involved in is the patient already saw me in the past, but me of the past was a dummy, and me of the past said you had cryon or ADEM, and I don't agree with me of the past. I'm like, hey, me of the past, you should have ordered a MOG, but they always say the same thing. That wasn't around when I was in the past. You order it now. How about this extensiveness here, Dan? Does it matter to you?
It does, it's a bit long.
Too long.
Too
Yeah,
long.
so that's the Goldilocks principle. It has to be just right. It cannot be too longitudinally extensive. It cannot be too much in the fat. It cannot be too much in the sheath. All those are big red flags that it is not quacking right.
Andy, can we ask in the room, just to be sure that we are on the same page, please raise your hands, those who have access to aquaporin 4 and MOG? It's not the majority.
Yeah, you better raise your hand after you leave this room. So one of the first things you got to do is you got to find out how to get these labs, okay? It's on you. Because if you treat with the steroids, you're the villain of the case because you didn't order the lab. So go find out when you leave this room. And Susie, can you tell them cell-based versus the ELISA for the aquaporin 4?
So you need to find out which your labs are doing because you need to be doing cell-based assays.
So that's the other point you need to know when you go home. Cell-based assay, aquaporin 4 and MOSD. Cell-based because the
Don't
ELISA.
accept ELISA, right? So in France, big country, quite advanced, we only have one lab that we trust, that's in Lyon for cell-based.
Wow.
Okay.
UK?
Well, we've got lots of labs because of obviously there's a big interest in NMO. So we send all ours down to Oxford, but there are a number of different labs in London and Liverpool to be able to send the bloods to, and it's such a well-trodden path now.
So you need to find out where your nearest cell-based aquaporin 4 lab is, okay? That's your job. And,
as well as going to find your histopathologist, by the way.
And so that's a duck A, short segment intraorbital enhancement, and that
Bilateral.
is goose.
Yeah.
See the bilateral or chiasmal. Don't fool around with chiasmitis.
And they tend to be quite chunky as well. If you get some beautiful coronal shots, the nerve, it's almost like it's chunkier and it does splay out a little bit into the orbital fat.
Dan, this person has enhancement of their intracranial optic nerve. They didn't have any pain with eye movement. How come? Doesn't optic neuritis cause pain with eye movement?
I would be very concerned about infiltration, not to mention.
What causes the pain in optic neuritis? Optic nerve doesn't feel any pain, right?
Right,
It's like-
so it's that the apex of the orbit, there are branches, sensitive branches, and the eye movement is the stretching of the zinzonial, right? And that's supposed to cause the pain. So intracranially, no.
Yeah, so that's a really important point because the pain in optic neuritis is trigeminal pain that's why it's pain with eye movement. So when the eye moves, it tugs on the nerve and the sheath. Those are painful. But like you could stick a needle right in the optic nerve and they'd go blind, but they wouldn't say that hurt. So we can do brain surgery on people and stick stuff in their brain and they're awake. It's the meninges that are painful. So that's why you can do awake brain surgery on people. But if it's intracranial like this, there's not going to be any pain, but bilateral, bad. And then what Dan mentioned, it could always be sarcoidosis, and if it's big and enhancing. So if big and enhancing, that's also bad. And Dan mentioned if it's going outside of the nerve, into the fat or the sheath, and so this one's the MOG one again. Can this be NMO, Susie, or it's MOG?
It's more
Yeah,
definitely.
so this thing is pretty good for the MOG. But you do got to worry about sarcoidosis. What are you doing for a sarcoidosis workup, Dan? In France?
Full body PET scan, probably.
Wow. Full body PET scan. UK?
Yeah, absolutely.
Really?
Yeah.
Straight to that?
Yeah.
So in USA, we have to do what we call STEP. You have to do the chest x-ray first, and a CT scan of the chest, and then they'll pay for the PET. I cannot get a PET scan without doing all those cheaper ones first.
That's why Social Security is so poor in France, probably.
So what the second homework assignment that you have is when you find your friend who's neuroradiology, you say, I went to this conference and this crazy Dr. Lee got up there and said that I needed to take you out for a coffee because what we're looking for is perineuritis, and if the enhancement is going in the sheath, bilateral, longitudinally extensive, because I don't want you to write impression optic neuritis on our reports anymore. So in the past, they could just say impression optic neuritis, but we can't do that anymore. It has to be optic nerve enhancement. Was it longitudinally extensive? Did it go on the fat? Is it bilateral or unilateral? And so one of the messages that I hope you're taking away is you need to have a friend and phone a friend about what your optic nerve protocol looks like in your hospital. So that's what I need you to do. Go find that friend. And in the sheath, that's very, very, very suggestive that it's modeled. And so if you look at what we were doing in the past for long spinal cord, longitudinally extensive is 3 segments in the spinal cord, multiple episodes, we're doing the cell-based aquaporin 4. I am doing it for even single episode of optic neuritis if it's not typical MS, and I'm doing it for short segments of spinal cord, even if it's short, unless it's clearly MS. And then the last thing I want to leave you with is this thing right here, which is the area postrema syndrome. That's unexplained nausea, vomiting, intractable hiccups. APS, area postrema. That's your vomit center right there at the floor of the fourth ventricle at the medulla. And that means you can have an NMO, no N, no M, no O, just APS, area postrema syndrome, plus the antibody meets the criteria for NMO, no N, no M, no O. That is amazing. And that's why the spectrum keeps expanding. And it's expanded to include brainstem presentations now and diencephalic presentations. So really you should know about these antibodies. I hope that you'll go look it up. I do want to thank my panel for doing such a great job as always. Please join me in thanking my panel and I wish you the best. Thank you so much for your attention. Now, hopefully you'll come to the afternoon session. Bye-bye.
Thank you, Andy.
Thank you.
Amazing.
Oh, that was good.